I will present the increased right ventricular pressure as a predictor of acute decompensated heart failure in end-stage renal disease patients on maintenance hemodialysis. Background of this topic is as below. Cardiovascular disease is a common complication and the most frequent cause of death in ESRD patients who are on hemodialysis. Dialysis patients with heart failure exhibit a lower 2-year survival rate after the initiation of dialysis compared to those without heart failure. Since heart failure is a progressive, complex clinical disease, it is difficult to evaluate its prognosis using only a few objective indicators. And we aim to determine the hemodynamic factors associated with acute decompensated heart failure events among ESRD patients without significant IHD or VHD who were also undergoing hemodialysis. We investigated 188 ESRD patients on hemodialysis in 2080, January to 2020, December, at Goshin University Gospel Hospital. Patients group 1 is who were admitted due to at least one episode of acute decompensated heart failure. Acute decompensated heart failure group have a hospital admission, visit to the emergency department, pulmonary edema, pulmonary congestion. Patients group 2 is who are not admitted. Hypertension is higher than systolic blood pressure 140 and diastolic blood pressure 90. Diabetic mellitus (DM) is higher than fasting plasma glucose 126. Hemoglobin A1C is higher than 6.5. And we performed standard two-dimensional echocardiography and the statistical package for the social sciences was performed. In this figure 1, it has explained the group we investigated study population. Of the 188 ESRD patients on hemodialysis, 87 were excluded, 101 patients were enrolled, and 30 of those patients were admitted to a medical facility due to acute decompensated heart failure. The groups exhibited similarities in age and sex, and there were no differences in the prevalence of hypertension and DM. The acute decompensated heart failure group showed a trend for a higher interdialytic weight gain (IDWG), but there was no statistical significance. Upon echocardiography, there was no significant differences in the left ventricular EF, LV and diastolic dimension, LV mass index, or E ratio between the groups. However, the acute decompensated heart failure group exhibited a significantly higher TRZ velocity and a higher IVSP. There was no significant difference in the time delay from hemodialysis to echocardiography. The acute decompensated heart failure group demonstrated a higher NT-proBNP level than the non-acute decompensated heart failure group. In regard to ion status, there were no significant differences in the serum ion, ferritin, and total ion binding capacity between groups. A multivariate logistic regression analysis showed that the TR jet velocity was an independent predictor of acute decompensated heart failure after adjusting for age and sex, and that the LVEF and E ratio were not. Most ESRD patients display more factors of heart failure when the objective echocardiographic parameters are considered. In this study, increased RV pressure, TRZ velocity, and RVSP was significantly different between the two groups and was an independent predictor of acute decompensated heart failure, whereas the LVEF and E ratio were not. Excess volume accumulation over long interdialytic intervals in hemodialysis patients results in greater LA and RA enlargement and RV pressure elevation, which clinically corresponds to pulmonary circulation of blood. This study had a single-center retrospective design, and the number of enrolled patients was too small to establish a generalized conclusion. We did not exclude other factors that may lead to hospitalization, such as inadequate dialysis, infection, anemia, and bleeding. And we did not evaluate other parameters of RV function, such as tricuspid annular plane systolic excursion, RV fractional area change, and RV strain. The timing of echocardiography was not distinguished as before or after dialysis, which can affect the patient's hemodynamic status. My presentation is over. Thank you for your attention.